he put her hand in front of the X-rays, and that's where they made that picture that you see. It's called a skiogram. You know, that's one of those trivial things. So anyway, a few months later, Becquerel, and does everyone remember the story of Becquerel? What happened with him? Okay, he had a piece of uranium in his pocket, and he set it in a desk on top of some photographic plates. Okay, later he observed that he had like a red burn on his chest, and so he was curious, you know, because, I mean, obviously he didn't know if it was the new laundry soap he was using or something else. But when he processed those photographic plates, he discovered that it left a pattern similar to the rock that he had placed on top of it. So he basically discovered radioactivity. And they discovered that it was very similar to X-rays as far as its effect on film. So from that point on, notice that they started realizing that radiation was bad for you. Okay, produced burns, and at first people just thought you were allergic to it. I don't know if you ever heard that history, but people thought that, you know, if you had a reaction to it or you got cancer or something, it was because of an allergy. But anyway, they decided after, you know, people started getting so many burns that they needed to control it somehow. So one of the first radiation units that we came up here was what they call the skin erythema dose. Basically, every morning when you were an X-ray tech, you would stick your hand under the beam until it turned red, and that would tell you how much radiation you needed to use on your patient. On Monday, you would use your left hand. On Tuesday, you would use your right hand, because that's how long it would take for the redness to go away. Okay. And the reason why they had to do that every day is because the X-ray tubes were Crookes tubes. And when the barometric pressure changed, that would change the amount of X-rays that were being produced. So when you had a high pressure, the air was more concentrated, and so you had a shorter exposure time. When it was a low pressure and storms were coming in, it took longer. So if you remember that back in those days it took about 20 minutes for an exposure to get an X-ray, you didn't really want to repeat that. Chest X-rays were horrible. Taking a deep breath, hold it, hold it, hold it, hold it, hold it. After you resuscitated the patient, then you could tell them what was wrong with their chest. Okay. So anyway, that's why they had to do that. So obviously there are what they call the radiation martyrs. There's a real good thing on the History Channel about, you know, radiation exposure and cancer. And in fact, in Germany, they have a, you know, some type of a monument dedicated to all the people that, you know, died, which is pretty much all of them. If you ever read the history of radiation, you know, it wasn't a very good outcome for most of these people. But anyway, this guy here, Clarence Daly, this was Thomas Edison's worker. And he used to test the fluoroscopic tubes. He'd stick his hand in front of them and make sure there was a good output and things like that. He died a very horrible death. You know, literally they were slicing him like a salami. He got cancers of his hand, and they just would whack off his fingers, and then they'd whack off his wrist, and then they'd whack, you know, I don't know how many surgeries he had, but he died at the age of 39.
Wow.
Okay. And then in that's 1904, so people really, you know, it wasn't very long from 1895 to 19, it was only 9 years before this guy would die. Okay. Very, very horrible death. Then the doctors started dying. This is where they came up with the concept that, well, they used to compare that there was premature lifespan shortening from radiation exposure. And they came up with this because all the doctors graduating from medical school were about the same age. And so if you went into surgery or, you know, gastroenterology or something, you would probably live to your 70 or 80. But the radiologists were dying off in their 50s and 60s from leukemia and all these other horrible cancers. And that's because they didn't have any kind of protection. You know, they used to look directly into the radiation beam. So anyway, you know, they got cataracts and they died from cancer. And then in 1925, we have this International Commission on Radiation Units and Measurements. you're actually going to see that they were formed officially in 1928. But again, people were realizing that radiation was not good for you. And then the other thing is, then we moved from the skin reddening dose to this one down here, where what they call the skin or the tolerance dose. So this is just the amount of radiation that you need before the skin turns red. Okay, don't worry about it. You'll have this. You don't have to write this down. But
Yeah, I saw it.
okay. So the tolerance dose was the dose below the level at which your skin would turn red. This kind of gave them a concept that there's two types of effects that you're going to see from radiation. One is what we call the stochastic effects. Okay? Stochastic is where you get cancer or the genetic mutations. Okay? And that, we don't know how, any dose is likely to cause that. So when we're protecting people, we're really trying to protect them from the stochastic effects. Okay? The non-stochastic effects are also called the threshold effects. And those are the ones where it takes a certain amount of radiation to produce a certain effect. So like for your skin reddening, it was like maybe 100 rem. So that's why they came up with this tolerance dose. They said that if you keep the radiation dose below 100 rem, then the skin's not going to get red or blistered. Okay. And the thing about the tolerance dose was it doesn't matter. I mean, anybody who gets exposed to it would have the same effect, pretty much. So then again, the 1930s, there was a lot of work going on in there. And then this guy, Bragg Gray, he came up with curves that show the effects of radiation as it passes through tissue. You'll see Bragg Gray curves mentioned all throughout radiation detection devices. Okay? In fact, the Gray was his partner, and that's why we have that unit called the Gray. I guess it sounded better than the Bragg. But whoever came up with it, but anyway. So anyway, he showed the ionization curves for alpha particles and things like that. And so they continually reduced the radiation. So up here it was like 2.2 Roentgen per day, and then now it's down to 1.1 Roentgen per day. And then notice in 1937 we had the Roentgen, which is, it's still considered the unit of exposure, but you notice that we don't use it very often, right? We're typically using the rad, and we're using the ram, or we're using the sievert and the Gray. The reason for, does anyone remember why we got rid of the Roentgen?
Wasn't it, it can't measure accurately after 2 mega?
Yeah, it can't measure anything, actually it's 3 MeV. Yeah, anything over 3 MeV, plus it doesn't measure particle radiation. So it can't measure alpha or beta. It's only for X-rays and gamma rays. So we can't use it for anything, we can't measure beta particles or stuff like that. Okay, so the Roentgen was our first official unit that we used. Then we had in 1946 the NCRP. Now these guys are the United States equivalent to the international thing up here. Okay, so in 1925 we had the International Commission on Radiation Units and Measurements, or the ICRP. And now in the United States we have the NCRP. So the National Council on Radiation Protection and Measurements. These are the ones that proposed all of the laws that you're currently working under. This is what they call a recommendation organization, in that they evaluate radiation effects around the world, and they make recommendations to Congress as to what kind of controls need to be done here to protect people in the United States. So that's why whenever an inspector comes to your department, he's going to ask you, well, where is your, where's your 10 CFR 20? Okay, that's the book that has all of the radiation protection regulations in it. It's a federal book, but all of the states that have their own radiation inspectors and things like that have to follow that book. Okay, so here in California, we have the Department of Health, and all of its standards are based on that Title 20, Chapter 10 Code CFR. Okay, So the NCRP is that. Then in 1948, the international, or the SI units are developed. If you remember that we came up with the SI units because we were having too many conversions between our traditional units and other branches of science. That was one of the main reasons for it. Okay. 1950, this was one that I grew up with, what we call the maximum permissible dose. Okay. Basically, you were allowed 5 rem per year. This is what we also call your lifetime or your cumulative dose. So in other words, you actually have a couple of measurements that we look at. You know that you're only allowed to get 5 rem per year, whole body, but you're also allowed a lifetime exposure. So if you've ever looked at your radiation badge reports, in there it tells you what your lifetime exposure is. Now, it used to be, this N was your age. So if you were 20 years old, so 20 minus 18 is 2, 5 times 2 is 10. That means your lifetime exposure at that point would be 10 rem. Okay, so whatever your annual exposure was, they would subtract that from your 10, and then that would determine whether or not you would be allowed to continue to work in radiology or any type of other radiation imaging. Okay, so long as you don't exceed that, you can continue to work. Okay, then moving along, and these are not very exciting, are they? Oh, never mind. Okay, so let's kind of get a look at what we're doing today. Okay, so we had the skin erythema dose, we had the tolerance dose, we had the maximum permissible dose, we had the effective dose equivalent. This was one of the first attempts to look at the damage that different types of radiation do compared to X-rays. We haven't talked about the quality factor before, but basically what we observed is that if you expose tissue to the same amount of radiation, you're not necessarily going to get the same result. Can you borrow your pen for a minute? Sure. Thanks. You got an extra one there?
Yeah.
Thanks. Absolutely. Okay, the quality factor works something like this. Okay, you take a 250 kVp X-ray and you expose either a volume of water or a sample of tissue. Okay. Now in the water, we're measuring how much ionization occurs. So we expose this to 1 Roentgen. Now the thing about the Roentgen is that it's almost equivalent to 1 rad. Does anyone remember what the definition of a rad is? It's radiation absorbed dose. Now remember, the Roentgen measures the number of ions that are produced in the gas. So it measures both the positive and the negative. So we measure the number of, well, if the unit that we use today measures 2.58 times 10 to the minus 4th coulombs per kilogram of air. In my day, we measured what we called an electrostatic unit, which was the amount of ionization that occurs in 1 cubic centimeter of air. I mean, the units are, I mean, if you multiplied 1 cubic millimeter of air and converted it into kilograms, you'd have the same unit. But basically, the SI units involve larger quantities of radiation. Okay? So basically, 100 ergs per gram. So in other words, 100 ergs absorbed in any type of material is equal to 1 rad. Remember that from way back when? Okay. A Roentgen is approximately 97 ergs per gram. So what they basically said was, okay, 1 Roentgen is equal to 1 rad. And it's also since the Röntgen is what we're using as our standard, when you have a standard, what number do you normally assign it?
1.
1. So if you take rads times quality factor, then you get RAM. So 1 rad times the quality factor of 1 is equal to 1 RAM. So basically 1 Röntgen equals 1 rad equals 1 RAM, if you look at it that way. But again, the quality factor, we measure how many ionizations occur in water. So we would expose this volume of water. We would measure the number of ionizations that we collect. You know, typically they have a couple of electrodes in there, and the ions will move to those electrodes, and then we measure how many we collect. Or we can take a sample of tissue, and we can irradiate it and look for an effect. Let's say that we're looking at how much radiation it takes to kill the tissue. Okay, so let's just say that it's 100 Röntgens to kill everything in here. Okay, because now what we're looking at here is what we call a relative biological effectiveness, or RBE. So if we're looking at tissue, it's RBE. If we're looking at just ionization, it's quality factor. Okay. So as a comparison with the 250 kVp X-ray beam as our standard, if we gave this thing 1 rad here, or 1 Röntgen, or whatever, and then we compare it to an alpha particle. So I expose here's my alpha particle, okay, and I expose this to 1 rad of alpha particles. Instead of 1,000 ions, I may have a factor of 20,000 ions. Okay? So what that's telling me is with a different radiation, even though it absorbed the same amount of energy, it produced 20 times the damage. So that's where the quality factor came in. And the reason you'll notice the quality factor, and the same thing here, if it took 100 rads to kill tissue, how many rads do you think it would take to kill the tissue using an alpha particle?
Like a 20th.
Yeah, 1/20th. So basically, if I took the same dish of tissue, and normally what they do is they'll take tissue, they'll grow it in 2 separate petri dishes. It'll be from the same sample. If I expose that, we'll find that it takes about 5 rads of alpha particles to do the same damage. So this is 20 times more damaging biologically if you're exposed to it. Does that make sense? Okay. So for many, many years, up until about 1991, this is what we call the dose equivalent. Basically, it's just the comparison of the rads that you've absorbed times the quality of the factor of the radiation that you were exposed to, and that's how we would calculate your RAM. Okay. But now we still use that, but we're using what they call the effective dose equivalent. So instead of just dose equivalent, now we've changed it to effective dose equivalent. And the difference with that is, notice it's still the amount of radiation that you were exposed to, but now we're also adding in another factor, which is the sensitivity of the tissue. So, in other words, when they were exposing that tissue doing an RBE experiment, they would find that, let's say, liver tissue exposed to 100 rads, 15% of the liver cells died, so it had a sensitivity or a tissue weighting factor of 0.15. So in other words, they would and this thing here, this dose is the number of rads that you were exposed to. The WR is that quality factor or RBE factor. And then over here we have the tissue weighting factor. So out of a sample of tissue, you expose it to a known amount of radiation, and then you calculate how many of the cells were affected. Okay, so 15% of the cells are affected, then the tissue weighting factor is 0.15.
The WR is the RBE?
Yeah, it's either the RBE or the quality factor. Yeah, quality factor actually only measures ionization in water. But if you ever look in radiation protection books, you're going to see that the RBE and the quality factor are pretty much the same. Anybody explain why? Why the relative biological effectiveness and why the quality factor are very similar to each other when we use calculations?
Is it because tissues are mostly made of water?
Because tissue's mostly, yeah, your tissue is about 85% water. Okay, and you're going. WT is the tissue factor.
So that's.
Yeah, the tissue weighting factor is this part here. The WR is the radiation weighting factor. So the dose in rads times the radiation weighting factor times the tissue factor. That's what we're using more or less now.
So the tissue weighing factor, that's how delicate that tissue is?
Yeah. As we start talking about radiation biology, you'll see that some tissues are more sensitive than others. You know, the bone marrow is the most sensitive. And so one of the things, you know, that's why if we ever suspect that you had a high radiation dose, the first thing we're going to do is a blood test. And we have you come back a week later and we do another one. Because of the short life of white blood cells, that's the first thing that we look at. You know, we know that white blood cells live less than a week, you know, anywhere from a few days or a few hours to maybe a week at the most. Red blood cells live for how long? 120 days. So you'd already be dead by the time that effect would show up on you. Platelets, they have about a 30-day half-life. So again, we look at your white blood cells because they're the most sensitive. But then as you look through other organs, you know, we look at the sperm, and the sperm is actually fairly sensitive. The ovaries, up until the woman is about age 18, they're sensitive, but after that, the eggs in the ovary are actually quite well protected from radiation. Okay. And you'll see that then epithelial tissue, so stuff that lines the gut, your mucous membranes and things like that, is the next level of sensitivity. And then lastly is your muscle and nerves. They're the least sensitive to radiation. They typically will have questions like that on your board exam, and we'll cover that in radiation biology. They'll list different types of tissue and their sensitivity. And you know, you'll typically something that says, okay, we talk about what we call an acute exposure. And that's typically anything over 100 rem in a short period of time. If you treat patients for thyroid cancer, you're likely to see this. Okay, patients that have thyroid cancer, you give them 100, 150 millicuries, they're very likely to get this. But there's a series of events that you'll see. One is called prodrome. That's also radiation sickness. Now, radiation sickness is like a flu, so the patient's going to feel tired, nauseated, may vomit. This is why you have to be on the alert anytime you treat these patients, because if they vomit, then you're going to be cleaning up I-131. Okay? You definitely have to be careful about the urination, but this is the first stage of what they call radiation syndrome. Okay, then the next thing is we have what we call a latent period. Now, the latent period is sort of like an incubation period. So it's from the time you were exposed until the time we see an effect. Now with the prodrome, and that high of a dose, normally you may or may not see anything after this. But typically the higher the dose, the faster the symptoms appear. Okay? So late period, usually fairly short. And then we have what we call the manifest illness stage. And again, depending upon the dose that the patient received, that's going to determine what kind of effects that we'll see. And then the last thing is what we call recovery or death. Now, the good news is there's some of these things that we can take care of. But basically, from about 300 to 1,000 rads, we have what we call the hematopoietic syndrome. Because remember, we told you that the bone marrow is one of the first organs affected. So typically, a person who's received 300 to 1,000 rads will see a major change in their white blood cell count. We have seen doses as low as 25 rem that produce a change in your white blood cell count, but pretty much that disappears after a short period of time. So the body is able to recover. But the higher the dose and the more damage that is done, the patient may not be able to completely recover. And in fact, one of the things you're going to see is they have a thing called the 450 LD 50 30 or LD 50 60. 450 rem is considered what they call the median lethal dose. So basically, if you have a population of people, if you expose them to a 450 rem, we would expect 50% of the population, that's what this is here, to die within a period of either 30 days or 60 days. They kind of upped it because people weren't dying off soon enough. What typically happens with the hematopoietic syndrome, people start getting infections initially. They usually die from the infection within a period of about 30 days. Okay, so that's about how long it takes to do that. The other thing is you start bleeding. Okay, so you either bleed to death or you die of infection or both. Okay, so they increased it to 60 days. So if you see LD 50-30 or LD 50-60, that's all they're doing is they're just measuring how long it takes for half of the population to die. Okay. And then from about 600 to about 5,000 rads, we have what we call the gastrointestinal syndrome. And what happens here, if you remember your anatomy, the lining of your GI tract has a lot of villi in it. Okay, villi are kind of unusual in that you have these immature cells down here, and these are called crypt cells. Okay, as they mature, they start going up the stalk, and then eventually, when they're at the top, they get to be high and mighty, and then they get sloughed off with the poop, kind of like corporate America. You get promoted, and finally they flush you down the toilet. One of the bad things that they observed about radiation exposure was the contribution by these two gentlemen called Bergoni. Whoops. Now I can't write this one. Bergone and Tribune Doe. Anybody who's a radiology tech will know this. Okay, basically these two gentlemen observed that cells that are rapidly dividing, immature, and undifferentiated are very sensitive to radiation. The older the cell, the slower it divides, the more differentiated it is. Now, differentiation means that if you look at it under a microscope, you can tell what type of a cell it actually is. Because when cells start out, if they're immature, we really don't know what they're going to do. But when they grow up, then we can say, oh, well, that's a liver cell, or that's a renal cell, and blah, blah, blah. So, the immature cell that's rapidly dividing, it's going to get killed by the radiation first. So that means that there's nothing to replace it. And so the patient winds up getting these like horrible ulcers and open areas on the inside of their intestine. You know, fluid leaks out into the digestive tract. They have horrible diarrhea. They typically die in about a week. So if you were going to select your poison to die from, if you wanted to die in 30 days, then 450 gram. But if you want to die a little bit faster, but a little bit more horribly, then the good old GI tract syndrome is the way to go. You normally die from hypovolemic shock because you lose so much fluid. You don't usually live long enough to get the horrible infections that you would normally expect from the hematopoietic syndrome. Okay, that's the good news. The worst news is if you get 5,000 or more REM. 5,000 REM is what we call the central nervous syndrome, central nervous system syndrome. And the good thing about this is that you typically die within about a 24-hour period. Basically brain swelling, spinal cord swelling, and basically you go into respiratory arrest. If you keep increasing these doses, death just occurs faster. That's so if you went to 10,000 REM, you'd probably die twice as fast. So 12 hours. The bad news again is that normally if you get that high of a radiation exposure, even with most of the interventions that we have, we can probably save you for some of the minor type GI stuff, but if there's too much damage to the GI system, you're basically toast. There just isn't any way to fix all the damage in there. So, this is where we're at today with that. Okay? And let's see what else we got here that was an interesting thing here.